learn a lot, find mentors, talk about your future, and to give you tools how you can learn faster. So tomorrow we have a platform called Ophthalmo University, and tomorrow it's going to be in Spanish, and it's going to be very interesting. So we're going to talk about glaucoma and sex. I mean, the amazing Gabo Lascano, it's talking about this. I don't know what it's gonna be, but I think it's gonna be very fun. And because of the title, there's so many people subscribing. So I think tomorrow is gonna be great. It's gonna be in Spanish. So for those who can speak in Spanish, then we're gonna be able to translate. Guys, sorry, there is someone with the mic open. Please just mute all the mics. Francesco and
Yes.
Thierry, they have open mics. Please just put it on mute because we have some echo. Okay. So today we have an amazing topic again: fake emulsification, how to learn it fast and efficiently. Who doesn't want that, right? Because even good surgeons need to keep improving and to keep learning through their entire journey. So we are present in almost every social media you can know. So please follow Phaco Mentors, and you're gonna have a channel there to talk to colleagues, to talk to mentors, to talk to people from all over the world. This is the quote, this is our mantra, and this is what we love. We believe that surgeons, they're not touched by an angel and in that specific moment, they're gonna find the solution right away and they're gonna solve problems. No, they rise to the level of their training. So if you train a lot, you're gonna be better and better. That's very important. Um, and it's an honor for me to have this amazing panel. Last week we had Latin America and Asia. This week we have Latin America and Africa and Europe. So welcome Dr. Vito Romano from Italy, actually in the UK, Kalu Anya from Nigeria, Francisco Aiello from Italy, Ter Ogo, sorry for it's hard to say the last name, Terry from Cote d'Ivoire, Costa de Marfil for the Spanish speakers. Borja again with us. Thank you, Borja, for being here from Spain and Barcelona. And Ladger, a very, very good friend from the house from Germany, actually in Andorra, and doing amazing stuff there in Andorra. He's going to tell us all about it. The approach today is going to be, as you guys know, the iceberg approach, right? We are used to see the surface. Right now, we're going to talk about what's happening under that big iceberg. So I'm going to do a quick introduction. Then we're going to discuss a lot with Ladger about how was his learning curve and what changes he saw like during these years. He's an amazing surgeon. You're going to see it. Vito Romano is going to talk us about the pathway to learn and some tips about incision and iris prolapse. Borja has an amazing talk. Just wait for it. Is in how to train when you're in training, right? When you are in training, you're in a special mode. So we're going to give you tools how to do it more efficiently. Anya is going to talk about nucleus management. Francesco is going to talk about basic advices and iris hooks, very important things while you're learning. And Thierry is going to talk about the ways how to stop a bleeding in the anterior chamber. Very interesting topic, and we're looking forward to it. What is Phaco Mentors then, guys? Phaco Mentors is a community. It's an ecosystem in where we want to give you the tools for you to become the surgeon you want to be. And right now, this community is getting larger. As you can see, we have a panel from all over the world, and every day we have an ambassador from every country in the world. So that's our objective to December 2020. We want one ambassador for every single country in the world. So I think we're gonna make it. And basically, we're gathering today because whether we like it or not, this is how almost 95% of places in the world is teaching cataract surgery. We're teaching cataract surgery with a human being, like you can see there laying down, in in an operating room environment that it's stressful and has a lot of things. We're going to talk a lot about this with Ladger, right? He trained this way. I did it too. I think all the panel did it the same way, but this is changing. We know that in 2020, there is a lot of pressure in surgery, not only surgery but surgical education. We have economic challenges. We have even ethical issues about how we are learning in human beings, especially Vito. I'm pretty sure you know a lot about this in the UK training, right? This is very important in places like UK. And also there is a lot of pressure in that surgical education happening in human beings. So this is how we learn. This is how we learn in 2020. We have a high pressure environment. We have time constraint, and sometimes we have to say it. We have a mentor that has they don't. He doesn't have enough time. He's in a hurry because he has private patients or other surgeries. So Ladger, I would love to know what you think about, because you train in this way, and you are seeing a lot of changes in the last years.
Well, Ivo, and hi everybody. Ivo, thank you very much for participating or letting me participate. I always love your webinars because they're so practical and so important. But I just come to the point. I'm probably the oldest here. The oldest. So the way I learned, you just mentioned it. It was the old world. So I was lucky actually because I had a mentor who showed me everything. It wasn't all the time very nice because as we all know, if you learn from a mentor and you are in these situations which you just described, it's stressful. The mentor not always have a lot of time. Frequently he has other things to do than just correcting what you're doing. So it's a very stressful and inefficient way to learn surgery. So when it comes to the first point, I think you of course need to get acquainted with all the theoretical know-how with Phaco dynamics of the Phaco machine, but then you have to start learning under or performing with your hands under a microscope. And this of course you can train without a mentor. But then, I mean, I did my training in Germany, but if you compare it, and I was lucky that I had the possibility to get the training, but there are many countries right now in Europe where you even don't have this possibility. I mean, the Anglo-American countries always have been very structured, and the training which you get in Spain or Latin America probably is very structured as well. But then we've just heard it, when you come to Italy, you don't get the chance. When you go to many Eastern European countries, you don't get the chance as a resident to try to practice. And in Germany, it's the same thing. In Austria and Switzerland, it's all the same situation. So apart from getting better and more efficient in what we want to learn, I think it's just unfair. And we have to give everybody the possibility to learn how to do surgery.
I agree 100%. And it's funny. I saw I and Vito, I think, can help us a lot, and also Francesco. They come from Italy. I saw a talk from a colleague in Europe telling us how you should treat the mentor so he can give you some surgery, right? Tips on how to behave to be in during residency to become a surgeon. And that's hard from some people, right? Because the dream of the ophthalmologist is always to become a cataract surgeon. But I'm going to ask them further. We did a survey and look at the number. The number, it's pretty big. We are more than 500 colleagues, and it's in Spanish, but I'm going to translate it to you. We and we're going to do this question to you guys. So whenever it's ready, please put it there and you can answer. But basically, I'm going to ask about the quality of teaching. And when we talk about the quality of teaching, almost 80% of people say there was a bit between bad and regular. even if they had a couple of surgeries, they think there's not a lot of transfer of knowledge or skills. When we talk about the number, because we always care about the number, right? How many surgeries did you do during residency? That's and look at the numbers. And this is people from everywhere. And there is, if you can see there, I can tell you that probably less than 20% did more than 50 cases. And Ladger, we could talk about hours about this, but are you a cataract surgeon with 50 cases? And I think there's a long way to go, right, after that.
Well, we all know the answers. So, but it's not the fault of the residents who want to learn how to do that. It's, I think, the fault of the system, and this has to be improved. And there are so many countries where structured education doesn't exist, and I think this is really necessary to be overcome. And the other thing is, I mean, mentors frequently, if you are lucky and have a mentor, there are surgeons. They may be excellent surgeons and they may be excellent ophthalmologists, but they frequently aren't very good in educating other people because they've never learned it. And there we have big differences in the different countries as well. Again, the Anglo-American countries are a lot better teaching residents in a different way, but then systems, the medical systems are completely different in all the European countries. For example, in Germany, we do most of the cataract surgery in outpatient clinics and private clinics. I mean, you can't teach anybody if you're teaching your private patients, because if something goes wrong, you have a big problem. So you can understand the ophthalmologists, the surgeons, that they're a little bit hesitant in teaching their residents how to do surgery. So what we have to do, we really have to come up with different ways to educate young ophthalmologists. And I think with the modern technologies which we have available right now, there's a very good chance that we can overcome this problem.
I agree 100%, Lager, and that's what exactly what we're going to talk about. So let's see the results here. Let's see how Okay, we have a 52 between bad and regular, and this is not judgmental. This is to improve. Let's see where are we and how you can improve. But we have about 70, almost 80% saying that the quality of education, it's regular and bad. And we have a 60% of people who do cataract, they do less than 10 cases. That's very interesting, right? uh, we have another two questions that I'm saving for Vito here, because he is in the UK and we know that he has a very long residency, but these guys, they do a lot of cases, right? They do a lot of cases during residency and fellowship. But my question to you, Vito, it's also, can you be a cataract surgeon if you don't know how to solve complications and do anterior vitrectomy? Tell us a little bit about your case. We're so happy to have you here. uh, we would love to understand how things work in the UK.
Thank you very much, Ivo. It's very interesting what you say. It's right, you're right. In England, it's very structured. There are 7 years and you need to do 50 cases each years for cataract surgery. So you end up normally to do 350 cases during your residency. And you learn also to manage your complication, to manage the challenging cases. And I think the main important things that you have your mentor that supervise you, and step by step you will be able to do that, to learn all the different steps, even the complication. I think to have to be assured that you have to perform more or less 50 cases or more every 6 months. You need you are quite relaxed. For this reason, they don't complain, I think, for the length of the residency. I think from my experience, I think if you had a good mentor, you will be a good mentor. I think you will pass this way to teach, and you will be as well the trainer, and so the trainee will be more relaxed to learn, and will have better results. I think overall everyone can be a cataract surgeon, and it's like just as you said, need practice and willing to do it, and you will become for sure a cataract surgeon.
Thank you very much, and we agree 100%. So I'm gonna go fast now because we want to talk about with this amazing panel, and what we want and what we were talking with the Latger, and I think we need it in Latin America, we need it in Europe, we need it in Asia, we need it in Africa. So this is for everybody, right? For all the community. We need to understand and this concept that we love about the wormhole, or how to hack time, basically, how to save time, how to save resources, how to save effort, and how to have better surgeons with better performance, and also, and this is very important for us, how a surgeon can keep improving during his entire journey as a surgeon. We have this program called the Phaco Mentors program, and we're again, if you take a picture into that QR, we can be in touch with you. We recommend a mentor from you. For example, Ania here had an amazing mentor. It's a very good friend and part of Phaco Mentors. That is Ishtiake from Bangladesh. So the idea here is to connect you, to a solution. This is basically the dream of our lives, and I think we're gonna make it happen. I'm gonna say seven to eight quick tips, so we understand what we try to say here. First, if you want to become a surgeon, we need to understand what is a surgeon. And I joke with this all the time, right? Always need to wear a smile, because to be a surgeon is like being like this guy. Okay, especially to be a cataract surgeon. Look at this guy using his two hands, his 2 feet, playing music. This is what you're gonna become, right? It's a brain, with 2 hands and 2 feet, coordinating and integrating. The reason, or the surgeon itself, have, you guys know it, has evolved. Before we were like semi-gods, we have the ability to cure eyes, and now we are all the time, facing, complex cases or complex situations. So it's not easy to be a surgeon, and you're gonna need to understand what a growth mindset is, because you're going to keep improving during your entire career as a surgeon, and you're going to face complications. You're going to think you fail, but you're going to have resilience. So failure is going to be a teaching lesson and not an ending point. So the growth mindset for us is going to be very important. The other thing is about training. You need to train. There is no surgeon that, an angel came and touched his hands and he became a surgeon. No, you need to train. You need to understand what good training is to get a mentor, and that's going to be the key. The journey is not going to be easy. It's going to be like climbing Everest. And for that journey, if you have a mentor, it's going to be great. You need to understand that first you're going to be competent, then you can become good, then great, and then why not to get to be a master? But that's going to be, again, a journey. And a mentor, that's the reason of the Phaco mentor's name, right? The mentor is everything in this journey. And even mentors were mentees at some point. So you need to understand that, it's going to be a journey. You need to understand you need to prepare the day before. You need to have a mental preparation. You need to have a team if you want to become a cataract surgeon. You need to understand the operating room and the surroundings. This is like your soccer field. You need to understand it. You need to understand the limitations, the good things, the bad things. What do you need to prepare? You need to understand the situation of the machines, the surgeon surroundings, the ergonomics. You need to understand that after you train, you're not gonna pick specifically your patients in which you're gonna start. you need to understand about the mental preparation. We love the mental preparation and something called the peak performance state. You need to be in the perfect, when you're doing surgery, there is a lot of tools that will allow you to be at the best uh, performance moment. And then again, ergonomics, and the afterwards. Surround yourself with good friends, surround yourself with good surgeons, record your surgeries, and at all times, see what happens. Try to have metrics of what you do so you can improve them. What we did so far is we did a lot of stuff with Phaco Mentors and Ophthalmic University. You can find these classes that we did with a virtual simulation in Phaco Mentors or Ophthalmic University YouTube. And also, if you like podcasts, I will strongly recommend for you to listen to these two amazing colleagues, Dr. John Ferris from the UK and Thomas Oitin from US. These are two podcasts that you can, listen in Spotify. You can listen into the Apple in the podcast application on even in Google about what they think about how education it's coming, what it's coming, and again, there is many sports fans here. Borja, he's smiling because he's a sport fan, and if we can see Usain Bolt using technology to improve his outcomes, or we can see basketball players having all kinds of metrics, or tennis players using every single gadget they can find to improve their performance, we can do that too in cataract surgery. So why not start learning? This is a short video in which we love this concept about removing the patient outside the learning loop, right? Let's try to learn in an environment that we can have metrics, we can have a mentor, we can have a good communication, and there is no the high consequence for a patient. Let's train in a way that we can have metrics and we can compare our metrics with a worldwide data, like we could do it in the simulator. We can do benchmarking. We can have objectives and try to achieve them. And we need to understand. To find the solution, we need to ask ourselves. We need to understand what is to be a cataract surgeon. So everybody there who wants to become a cataract surgeon should understand this concept, that you're gonna be right, like Neo and Morpheus in this encounter. Morpheus is telling Neo what a phaco surgeon is, and it's a surgeon with two hands and 2 feet working together, a patient laying down, the correct ergonomics, and especially the correct mindset and the correct decision making, right? We love these 3 pillars about the correct mindset, the correct cognitive skills or the correct decision making, and the correct motor skills on how to put your hands and how to train. How we can learn faster? Well, how we can learn faster, we're going to talk with this amazing panel. Right now, I want to thank Vito to being here. Ladger, thank you so much too. Anya is here with us, Thierry and Francesco. Borja, of course, with us. So we're going to start talking about this. I would like, before we start with each panelist, some quick thoughts about what you think about all this introduction. Borja, you can start.
Well, hello, everybody. Thank you, Ivo, for the kind invitation. You know how I like the new technology that we can use for training, not only the junior trainees, but also us as experienced surgeons. I will talk very little about some things that we can use these days. I think that it could be a topic of some other day because we can discuss about it in length. But in my 5-minute presentation, I will discuss a few of these tips. I've been honored with having very good mentors, like Ladger said. I totally agree with him when he says that whoever has a good mentor becomes a good mentor, and a good mentor is very, very important. I will also talk about that in my talk. And thanks to all these mentors, I'm trying to pass on to the junior trainees all this knowledge. So hopefully in the future, we can be more and more mentors, and we can all learn and improve in our cataract surgery.
Excellent. Anya, any thoughts about this introduction?
Yes, I'm not bothered when during the survey, some people had fewer cases of anterior vitrectomy during their Phaco training. I think it's a good sign somehow because it implies there are fewer cases of complications. So while I was in training, I had very few cases of um, capsular rent, and that also meant I had fewer cases of anterior vitrectomy. So if a resident says I did less than 10 in my training, I will look at it from the other side. That is a good sign because there were fewer patients who needed anterior vitrectomy. But on the other side of learning, because one has to master what he does. So the fewer, the less mastery. But the fewer, the better the outcomes of the surgeries. That's my thoughts, sir.
Excellent. Thierry, it's great to have you here. You're on mute. Any thoughts about this introduction?
Thank you very much, everybody. Hi. And for training, my mentor told me, when you have a good mentor, you can have a good student. So if you have a good student, you have, and I think that it's important for the student to listen carefully what the mentor say to you. Very, very, very. Because when you will be in your office, when you will be in your operating room, it will be no mentor. It will be only you and the patient. That's what I think.
Thank you. Thank you very much. Francesco, it's great to have you here.
Ivo, do you allow me one comment?
Yeah, sure.
Because we're talking so much about mentors right now. It's a luxury nowadays to have a mentor, and there are many people out there in the world, and they don't find mentors and they don't get mentors, and I think we have to find solutions for them as well. And this is when we're talking about to learn fast and efficient, a very, very important point.
I agree 100%. That's our main objective here. Francesco, it's great to have you here.
Hi. Thank you very much for the invitation. It's a pleasure for me. So two quick things. So first of all, I had two training. My first training was in Italy because I did the residency in Italy. And as you said before, in Italy is not great, the training, because unfortunately, the time in the operating room is always short, so it's difficult to find somebody that wants to spend time with you and in the same manner finish the list on time. Then I had my second and real training in UK at Moorfields Eye Hospital, where I start Phaco since the number of 50 and arrived at number of 2000 in 3 years, more or less. And my first year of cataract fellowship, I did almost 700 cases. So I could measure the difference between UK training and training in Italy. Definitely you need occasions to measure your hands and to stay in theater. But also what I want to stress is that the cataract surgery is first of all in your head and then in your hands. You can't do a surgery because you have a great hands, you have a steady hands, without taking the right decision at the right moment. So I remember when I was at Moorfields, I used to attend the teaching, the cataract surgery, the cataract teaching with Brian Little, that now has retired, but is famous worldwide, to be a very good mentor with the great videos. And I used to spend 1 hour every single week for a couple of years listening his teaching. And this allowed me to take the right decision in the right moment. And I still remember his advices like 5 years later. So remember, I will say to all the participants, remember, guys, to study, to chat with the mentors, to chat with the other colleagues, and to watch a lot of videos or webinar like this.
100% agree. I 100% agree. I love the way you said it, right? The surgery is not in your hands, but in your brain. And I will go again to this concept about not only motor skills and how to move and position your hands, but the cognitive skills about how the decision making and the mindset skills to be in the perfect mindset in that moment to a peak performance. And look at this, this video. We love this video about look at it, Francesco. If it's so important for us, we think about this brain and everything you need to control when you're becoming a surgeon, right? It's a resilience, it's how to face complications, it's repeatability. There is so many things: high focus, concentration, critical thinking during surgery. So we agree 100%. So we have, before Vito is going to start sharing his screen. We have Luz Marina Melo that she was for us to translate, and Zoom is not allowing us to do the translation into Spanish, but she's an amazing mentor as well. Luz Marina, you have any thoughts about this introduction?
Well, thank you, Ivo. Well, I think that you nicely described the present and futuristic way of training. You touched all the aspects about training. And well, it's very different the way I got trained and the way we are training our trainees right now. Right now, through this pandemic, we have had the opportunity that the fellows in training had been using very, very much the eye simulator. And we've seen their improvement now with hands-on in patients, how it was very easily. And we've been using also, before we had the eye simulator, we have another dynamic simulator that I really recommend. That's the Kitaro. The Kitaro system, I think it's something you must consider and introduce into your trainings.
Thank you very much, Luz Marina. So Vito, we're all ears.
Can you hear me now?
Perfect.
Yes. So thank you, Ivo, again for your kind invitation. It's a pleasure to be here. So as you said, also Francesco said, it's very important to grab every opportunity to watch or see cataract surgery, because the situation will happen again. And as you said, it's in your mind, and everything you already saw this thing and you know how to act. I think since probably medical school, if you have the opportunity and you are sure that you want to be an ophthalmologist, because the cataract is the main operation in ophthalmology, you can really go and watch, assist the cataract surgery. You will learn the different time, the different kind of complication that can happen. And this is the main thing. Go to any kind of a training, and then you need to put your hands on. So you need to do your practice with the cataract surgery in the wet lab or eye simulator with the surgical microscope. You need to learn which is the distance, how to see this kind, how to approach the eye, how to move your, as you said, your feet, your hand, everything. Your ergonomics is all very important. After done that, and this is just matter of how much how much time you put into it, and you will be faster and faster. More time you put into it, more faster you will be. And then you can practice with your mentor doing cataract surgery. If you practice, probably you'll go step by step, but I think will not take long for you if you already did a lot of wet lab. And then you can do challenging cases, and then you will be ready to go. I think overall, if you have a good exposure to cataract surgery in wet lab or in theater, probably it's a matter of weeks that you can learn to do cataract, probably in weeks or months, but depend a lot from the number where you are exposed to. And I will focus today on the iris in prolapse. So it's quite a common complication, and it's quite important because it can increase the postoperative inflammation, the hyphema, radialysis, and increase the risk of posterior capsular rupture. So it all matter about the wound construction. The wound, if you construct a good wound, it can be watertight, it can be stand and intraocular pressure very high without iris prolapse. You need to keep in mind how to prevent this thing. When you approach an eye, not all the eye are the same, and the main thing is you need to be in mind which is the distance between the inner part when you go in the eye and the iris plane, what they call critical area of negative pressure. If this one need to be far away from the iris. In a patient that is a high myopic, so this tunnel can be a little bit shorter, and probably it's convenient for you it's shorter because you don't distort the cornea, you are able to see, because normally the high myopic is quite deep camera. Instead, if it's a hypermetropic, so the height is short, anterior chamber is short, you need to have quite a big tunnel. Overall, we can say that the tunnel can be 1 millimeter, but you need to adjust according to the eye, to the length of the eye, I think. And this is the critical. What's happened if you don't do that? If you don't do that, there is we know that there is a different pressure from anterior chamber and outside, and outside of the eye. And as soon as there is a breach, so the water can come out, and also the iris. If the iris is in this critical area, will come out and will be inside of your wound. And this can cause what we said, like iris damage and inflammation, hyphema, and then after all the other panelists will speak about it. And this can be a problem even, and can also cause a posterior capsular rupture because it becomes everything more complicated. So what to do in case if you fail your wound construction? So watch out intraocular pressure. Don't overfeed the anterior chamber. So remove the excess viscoelastic before that of resection, or lower the intraocular pressure or bottle eye and decrease the aspiration flow rate vacuum, because all these things can cause a high difference pressure and between in and out the eye. Support the iris hook after. I think Francesco will speak about it. And in case the eye prolapse, don't rush, decompress the anterior chamber first and then repose the iris. I think these are the few tips that are regarding the iris prolapse I want to share with you. So
very interesting. Thank you very much, Vito. Let's see, there is a couple of questions. We're gonna leave them for the end. We have a couple of questions from the audience. Thank you very much. And I think it's, you have a very interesting situation being from Italy, but in the UK. What do you think are the good things we can learn from the UK system?
I think for the UK system that the patient, it's kind of, when the patient come in the theater, in the hospital, they know that it's university hospital. They know that they can be have a surgery by a trainee, and they accept that. And this is probably the big step between the two countries. I think in Italy or in other countries, they probably they don't think the same, and it's more difficult for the trainee to feel confident and to be less stressful for them instead. So that's it. This is, I think, the main difference.
Thank you very much, Vito. So Borja, your next amazing title, I'm dying to see it.
Okay, so I hope that that nobody is
nice
angry at me. So after thank you, Ivo, for inviting me. After what we discussed about the topic, I came up with this idea of basically putting this title to my talk: how to train when you're in training. And I'm going to try to give a couple of tips on very, very broad tips on all the things that we've been discussing, because like I said before, we could be talking about this for hours. So yeah, I have no financial interests. I'm going to be presenting some programs and things that I have no interest at all on. This is just a quick slide. This is how the training to become an ophthalmologist in Spain is. It basically takes about 11 years to complete full training, with the last 4 years as a resident. And in those 4 years, you're supposed to be learning every single thing about ophthalmology, about every single surgical technique. And like we said before, there's a lot of time constraint. So what we're doing now, what I believe we're doing now with our junior trainees, is basically teaching them how to swim like this by throwing them in the swimming pool. And I think that we should change that. I think we've been through that road, and we know how painful it is, and we know how unnecessary it is sometimes. So I think we should change that. So some of the key points that I think are important for learning or even training cataract surgery are basically these four. Learn the basics about the surgery, especially when you're a young trainee. Mentorship, we've discussed a lot about it, and I'm going to give a couple of thoughts about that. We have also mentioned that practice. That is the key to become an excellent surgeon. And the last one is, I think, is becoming more and more important, and I think that Phaco Mentors has a lot to say about this, is pass the knowledge on to the next generation. So the basics, we need to learn how, why, and what cataract surgery is. And like Francesco said before, you have a lot of resources these days, thankfully, to learn all the tips, all the steps about cataract surgery. Obviously, if you are lucky enough to have a mentor or even a coach, I'm going to talk about this distinction later, that would be excellent. But if not, at least you can assist surgeries, you can read books, you can watch videos. There are lots of channels on YouTube with lots of excellent videos. There are plenty of platforms about specific types of surgeries, or you can attend webinars like this, in which we discuss about our pains and successes in surgery. Some of the common mistakes, these are not all of them, but I thought they are quite important. Some of the common mistakes we should avoid when we're training are thinking that quantity is better, should be over quality. I also I did a fellowship in the UK, and I know a little bit about what Francesco and was talking about earlier. And yes, they do have a lot of numbers, but how good are these numbers? Because numbers are not so important, especially at the beginning. You have to learn the technique, the good technique, before you move on to having more and more numbers, adding up numbers. Also, another mistake, the faster the better. We see all our senior surgeons when we are young, and they do cataract surgery in 10 minutes. Somebody can do it in 7 minutes. Somebody can, and it's kind of like a competition. And we think that we can do that. That's a huge mistake. Speed comes with efficiency. The more you do something, the less time you spend in not important things. So when I will say this, when I did my first cataract case, it took me 45 minutes to finish. I was sweating, and now I'm doing my cases in roughly 17, 18 minutes. I don't get impressed with speed. I'm not obsessed with speed. I'm more obsessed with trying to do things properly. And this is a big one. We should always know our own limitations, and we should increase the level of difficulty of our cases as we grow as surgeons. This is not only for the junior trainees, this is also for senior surgeons. We should never do something that could jeopardize our patient's safety. Mentorship. We could be discussing about this all day. Mentorship is not just training. Mentorship is giving motivation, giving piece of advice, supporting our mentorees, obviously coaching and giving them directions. Right now, what are we doing? We are doing this. We just think that by teaching them how to do surgery, that's enough. We're good mentors. We can put our medal on, and I don't think this is the case. But when we focus on cataract surgery, on training per se, we should kind of like have this in mind. I think we should be giving an increasing level of autonomy to our mentorees, to our trainees. I would recommend doing a step-by-step teaching, starting from the back. This was something that I put for a presentation about training in Spain. I said, okay, what we should try to do, we should try to allow our first-year residents to start like by doing some minimal movements in the eye. If you are lucky enough to have the IC surgical simulator like we do in our institution, you can spend a minimum flight hours like pilots do before you actually do real surgery. This will, it's not a perfect tool, but it's very useful because you acquire all this necessary finesse to navigate inside the AC, and you are less likely to have complications. The main problem is that it's very expensive. The second-year residents could be doing some steps of the surgery. We're lucky that the cataract surgery is very well step organized surgery. So you can start with IOL implantation maybe and viscoelastic aspiration, then move on to the incisions, capsular excision, and so on, so on. And then if the trainee surgical skills are good enough, a third or fourth-year resident can do full cases, either supervised or unsupervised. As a mentors, we should always keep in mind that we should be flexible and move together with the trainee surgical skills. Nobody is the same as the other person, so we should move with them. This is a good mentorship and good training. The third point would be practice. Practice, practice, practice. We know that practice makes perfection, and the more you practice, the more natural, skillful, swift, and steady your work will become. And this is very, very important. Sometimes I was told by one of my mentors that for improving the movements, the fine movements in my non-dominant hand, I could be cutting the fish with my left hand. If you do this at home with very simple tasks, you will definitely improve your non-dominant hand, and that will help you in your surgeries. What resources we have? I just put here a few of them. We obviously have wet labs, like with porcine eyes, even with human eyes. Sometimes if you're lucky, this is a picture of one of our residents in our wet lab in Barraquer. You also have some dry lab, very useful tools like the iLab. Here you have the information on that. These are real pictures of the device, and it's a very, very useful tool for you to practice capsular exits. You can even do this. If you go online, you will see that this is a small box, and you could be doing this while you're watching TV. It's very useful, and it's about practice, 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 and you will become better and better with your capsular exits. You obviously have the IC simulator. This is the simulator I'm most familiar with. We have it at our institution, and I also used it in the UK. These are a couple of pictures. There are lots of videos on the internet in which you can see all the videos of the exercises you can do. This is not like real surgery, I know, but it helps a lot. It even helps for those trained surgeons who have been out of practice for some time to regain those skills that they have lost. Imagine after, I don't know, breaking your arm, you're a little bit tight. You can use this before you do safe surgeries in your patients. And there are lots of training handled on programs. I put here a couple of them, which maybe the most popular ones are those in India. Here are some that I could find on the internet. Most of them, or almost all of them, are based on the surgeon's skills, and they go from 2 weeks to 8 weeks. For what I've heard from some colleagues of mine who have tried them, yes, you can do lots of cataract surgeries or lots of steps of cataract surgeries, but you don't get a real training or a real mentorship. I don't know if anybody has any comments on that. The one that I'm familiar with, the one that I'm familiar with is this one in Brazil, Phaco lab. Fabiano Brandao, a very good friend of mine who we did residency together, has put a very nice hands-on program in which he teaches cataract surgery under supervision, starting from the back and step by step. And he only, the surgeon only moves forward if he acquires the necessary skills to become a good surgeon. Here, if you want, you can have some information on this here. And the last one is not something that we should like just discard. I think it's very important. We've discussed about this. Those of us who have been lucky enough to have a mentor should be passing on that knowledge on to the next generation. We should not do to others what they did, in this case, not do to us. There are some places, especially in Europe, in which senior ophthalmologists are afraid of losing cases because maybe the countries are small, or maybe they don't want anybody to become more popular than them, and they basically put it very hard for their trainees and their mentees. So I think we should avoid that. We are in the 21st century. We are still teaching like we did in the 19th century, and now we have a responsibility towards our junior trainees, and we should be creating groups like Phaco mentors for standardizing training, and also growing this feeling of a mentorship that is so necessary in so many countries. Here's my email in case anybody wants to contact me. I will be very happy, and thank you very much for your attention.
Thank you very much. As always, many amazing concepts. And I think the key here is you're showing so many different ways, because we have people here commenting that in their country, they don't have the capability, or they have, training centers far away. You showed so many different resources. I think the key here is to understand which of those resources are efficient, are fast, they have a good mentor, and they also have people who are passionate and willing to teach, actually, right? Because, we have to be completely honest. It could also be like a business, but there's a lot of people so passionate out there to teach. We just need to connect the dots. Thank you so much, Borja. Amazing things. Right now, I have a very interesting video from Anya, and I'm gonna start. I'm sharing the screen, and I'm gonna start whenever you want. Anya, thank you for being here with us.
Thank you. Today, this surgery was just done today, a few hours ago. You can play the video, please.
Yes. It's running.
I totally agree with what Borja said. It's not about the numbers. It's about the quality. It's not about the speed. I've never believed in speed. This should be about 9 point something minutes. The total surgery was about 15.26 minutes. So nucleus delivery, as a detailed, took most of the time. After the capsulorhexis, I think I will agree with every other panelist that the nucleus delivery is now the challenge before us. And it's not an easy challenge, because it's only at this stage that there is ultrasonic power being released in the eye. And with release of ultrasonic power comes energy, the heat, which is what we do not want to damage the cornea endothelium. So in my mind, like Vito said, surgery starts from the mind first before it comes to your skills. So what is in your head comes out in your skills. Even if you have good eye coordination, it may not be much. So in my mind, I tell myself, first of all, protect the cornea. At this stage, I will agree with no speed, take your time. You don't have to be in a haste to finish and go to the next patient. So when I'm doing my nucleus management, I do not have in my head, next patient, get next patient ready. No, I try to avoid that. So what I did here was to do what I have always thought was necessary: hydroxypropyl methylcellulose. Whenever heat is produced in an eye, it follows that there should be coolant. The BSS we use is such a coolant, but the BSS is not enough because it doesn't coat the endothelium of the cornea. So I have in my head 1 quadrant hydroxypropyl methylcellulose, 1 quadrant HPMC, 1 quadrant HPMC. So I'm carefully going in to make sure I divide the nucleus into manageable fragments. But each division, each division comes with refilling the anterior chamber with hydroxypropyl methylcellulose. This is because I'm just putting the HPMC now, I want the endothelium to be coated back again, so that every manipulations I'm doing in the eye, I'm too sure the eye is safe. The setting at this stage in my Alcon Laureate machine was power of 35%. And I had to put it on the aspiration flow rate was 30, while the vacuum was 450. So the power was slow enough, but still, I didn't want to take chances. This turned out to be a very soft cataract, so I had to be extra careful with what I was doing. So even with low settings, it's still safer to do, in my mind, what I call 1 quadrant HPMC. Each quadrant manipulation, please refill the anterior chamber with HPMC. The advantage is you have your divisions all done, but then the endothelium is well protected. So I finished the divisions and I'm refilling the anterior chamber with hydroxypropyl methylcellulose again. I want, like I mentioned before, whenever there is heat in the eye, it's also implied there should be a coolant. BSS is a coolant, no problem, but it does not coat and give a barrier protection to the corneal endothelium. So whenever I engage 1 quadrant, okay, this was just done today. I tried to edit it as much as I could before sending it over to Ivo. It's okay. I'm trying to clean up 1 quadrant now.
You want me to go faster?
We can make it faster, yes.
Okay.
Okay, so 1 quadrant is done. I refill again with hydroxypropyl methylcellulose. So whenever a quadrant is emulsified, I assume in my mind patient safety first. I come out again, refill with hydroxypropyl methylcellulose. Now, I could be wasting time in this. I agree with what Baha said. It's not in the numbers, it's in the quality of what has been done. You could do 50 in a day, it's okay, if you have the strength, and you have the patience, but what of the quality? So I pick the 3rd quadrant, emulsifying it carefully. Like I mentioned, it was a soft cataract. I thought it was harder than this. So back again, I have to refill again with hydroxypropyl methylcellulose. I think I did this more than 10 times, just within a space of the period of the surgery. And I want to mention that the rest of the surgery, from the incision, go to cortical cleanup, and intraocular lens implantation, and the visual elastic cleanup, didn't take up to basically 4 minutes or so. But the major time I spent in the surgery was in this. I am doing nucleus management. And I think when we are passing on information to the younger generation, we need to let them know it's not in the numbers. Professor Istiak made sure that entered into my head. Always take your time and get it right. And finally, I'm done with the surgery now, with the nucleus management. And the next was to do the cortical cleanup, which didn't take much time. And before we knew it, it was all over. So my take is simple. Safety first, before we talk about speed. Speed should come with efficiency, just like Boaz said. I totally agree with him. Then it's not in the numbers. Even if you do one in a day, be satisfied with that one. I want to revisit what I mentioned about anterior vitrectomy. If one is careful, obviously, there will be less chance of capsular rupture. And it's possible in a week, you may not have done anterior vitrectomy. So in one side of it, so carefulness with tissue management, carefulness with the manipulations inside the eye would give us less complications. And I guess that's why it is called fast, but most importantly, efficiently. Thank you, please.
Thank you very much. Thank you very much, Anya. It was very, descriptive, and I think it's one of the most important steps of Phaco. Thank you very much. And there's a lot of people with many tips. And also, Ladger, do you have any comments? Also, a great surgeon, when you're learning, especially when you're learning nuclear extraction. And we're gonna make Francesco getting ready, so he's next.
Well, I think the biggest complication, I mean, not everybody knows, is the rupture of the posterior capsule. And when this happens early, then you may have a problem. And a situation like this, fortunately, we don't have that frequently. And to learn how to manage a situation like this is especially challenging. And if you don't do things right, then you can end up having a catastrophe. And the problem is, even if you do the surgery together with a mentor, then you are immediately under stress. So I really would stress my basic comment in the beginning, that we have to apply modern technology to train these situations better. I think this is very important.
Completely agree, Ladger. So Francesco, it's a pleasure to have you here.
Thank you again. Talking about speed, I always had something in mind, like if you want to go fast, go slower. What do I mean with this? If you want to try to accelerate the surgery and you are in doubt if to use or not Vision Blue, for example, don't try to find the shortcut, so skipping this step, because this will make you in trouble. So just try to go a little bit slower, doing all the proper step at the right time, and you will end up the surgery with no complication and potentially faster than not having using these extra steps. So I will start my presentation, and I will say thanks to Lisandro to helping me to show the slides with some tips. If we can go to the next slide. Thank you very much. So this is something that I learned in UK. Be ready for your first time and follow the 5P rules. There's an animation, so you can go ahead. The 5P's rules is proper preparation, prevent poor performance. So try to be ready for your first surgeries. And what has helped me a lot was this kind of simulator, the IC. I have no financial interest, but I remember spending every day 1 hour for a couple of months, every single day, doing this, trying to do some movement inside the eye in this simulator. I found this simulator really good. Why? Because it does help your mentor to trust you. Because the first time that a surgeon or a resident start doing the surgeries, what scares the mentor is how fast or not very good and precise the instruments they go inside the eye. So this makes the mentor a little bit scared. So the threshold to swap the surgeon can be quite low. So the simulator does help to increase the dexterity to use the hands and to move the instrument inside the eye. So the first time, all the movement needs to be very, very slow and precise. We can go to the second. So some general tips. When we have this large audience, it's always difficult to find the right target to give tips. So I included some very basic tips, and then we will see something a little bit more difficult. So first of all, record your surgery. This is a must. If you don't record your surgery, you can't learn from yourself. You can definitely learn. You can understand the mistake you make, and you will make probably at the second surgery as well. So do record your surgery and ask your supervisor to review the video with you, or review the video with even with your colleagues at the same level or just 1 year older than you. It can help. So watch other videos, and YouTube is a great resource. I remember I arrived in UK in 2011, and YouTube was just at the beginning with the surgical videos, but I spent a lot of time looking at these videos, and I learned a lot. As I said before, cataract surgery is first in your head before then in your hands, so take the right decision. And in brief, you have to think when you do your surgery. So continuously think what I'm doing, what I expect from this movement, and what can happen. And also remember to be nice with your supervisor, because he's putting a lot of effort, and also he needs to be brave to let you stay inside the eye by yourself. Next. Something really easy, but the patient position is the most important thing, and also the surgeon position. So if you are sitting uncomfortable, it's very difficult that you can end up the surgery, because you will start to have pain in your neck, in your back, and your arms. So and your hands are going to shake it at the end of the surgery. So try to set your position properly, ask for help, and also try to set the patient position very comfortable for himself. And remember to say the magic word that are chin up for me, please, and look at light. So chin up will make the eye parallel to the floor, and this will help the visualization of the eye and the eye structure. Usually, I don't advise to tape the forehead, the patient's forehead. Why? Because if the position does move, it's quite difficult to go back to the original position. So unless there's a basic tremor and a head tremor, I always advise to avoid it. And know how to put your drape properly. I don't want to see eyelashes on the way. This is the first sign of a good start of the surgery. Next, please. Thanks. This is a funny position that I use to do the surgery. This is me, and is what my mentor Vincenzo Maurino used to call the duck position, with the legs open and not underneath the bed. This allowed the bed to go very low, and this would relax your shoulder, but also your elbow. And also, I always advise not to use the arm rest, because more than helping you, it does stuck you in one position. And because one of the key point of the cataract surgery is the fulcrum of your instrument inside the eye, to avoid to pressing on the wound and losing fluid from the anterior chamber. So having the chamber that is ballotting up and down, you have to tilt your instrument, and this is only possible if you move your elbows, and then your wrist, and then your hand. So I always advise to avoid it. Despite at the beginning can be a little bit more difficult to have steady hand, but then it will come much better. So this is to go inside the operating room. This is one very good friend of mine, Luis Fernandez Vega from Oviedo. And sorry, Vito, not to putting a picture with you. Me, Luis, and Vito, we shared some training in corneal surgery at Moorfields Eye Hospital. So let's go inside the operating room, and I do have a video on how to put the iris hooks. So iris hooks is not difficult to put it. It's more difficult to do a cataract surgery with small pupils. So take your time, do your incision. I do with the keratom with only one grasp with the notch forceps. So one grasp and three incision. Then you can try with the intracam phenylephrine to try to have a little bit more dilatation. Doesn't work in this case. There are branded products to dilate pharmacologically, or you can put 7 drops of sterile phenylephrine in 1 ml. Then you try with the viscoelastic dilatation. Doesn't work. Remember, before using the iris hooks, to lift a little bit the iris with viscoelastic. Otherwise, will be difficult to insert the hooks inside. So avoid to overfill with the anterior chamber with viscoelastic. Sorry. Otherwise, the iris will be stuck on the lens. I always put hooks underneath my main incision. This will stop the iris to go into the main wound. So I first of all remove all the hooks from the box. Otherwise, it will be difficult to go up and down with your magnification. You do usually 4 hooks are enough for almost all cases. So you do your incision, and then you put all the hooks in. Try to standardize your technique. First of all, I remove all the hooks from the box, and then I do incision and hook in, because if you do all the incision first, then you will lose your opening. So I do the incision, and then I put the hook. Then if you struggle as the hook opposite to the main wound, if you struggle to find space, just remember that you can always go inside with viscoelastic, lift the iris up, and then it will be much easier to insert the hook. And then the last tip will be try to engage the iris with the all hooks first, and then you pull the hooks circumferentially. This means don't pull it the opposite hooks. Otherwise, you will end up with the cut pupil, and you don't want it. So you do it clockwise or anti-clockwise. Try to be nice and doing a regular shape, like a quadrat. And remember to, when you do your case, and remember to remove your hooks before removing your viscoelastics. This will keep the anterior chamber stable. It's quite easy to remove it. You pull it a little bit, your butterfly, then you push inside, and then you use your butterfly to rotate the hook. Otherwise, we'll get stuck to the iris again, and then you pull it and pull it. You don't really need to hydrosuturing the iris opening, but if you want, you can do it, but you don't really need usually. And I hope this was helpful somehow. We can go to the last slide. Just okay. Just the last slide. Only my email, just in case you're, or better, my Instagram contact. Just if you want to ask me some question, you can write me freely there. Thank you very much.
Oh, thank you, Francesco. It was amazing too. So many tips. I think this is going to be a class that people can, because that's one of the most important things, right? We have so much information now. Now the key here is where is the quality information, how to access that information fast. And everything is going to be in the YouTube channel, for the future. But I think people learning, can come back to this class and learn many, many, many things. Thank you very much for your tips.
Thank you.
Just to finish, we are really very good with time. We have Dr. Thierry. We had some problems with the slides. I don't know if you were able to send them or you're able to share them, but we will love to hear from you, Thierry.
Okay, at the moment, I will make my speech without slides. And
I'm sorry.
we have to talk about the complication during the cataract surgery. Talking about the bleeding inside the anterior chamber. When it's bleeding inside, you think about sterilization, but you can't do sterilization inside the anterior chamber. It will be very difficult. So we have to have technique to stop the bleeding inside the anterior chamber. One technique is the technique. Take a syringe, 5 cc, with a cannula, a recoughed one. Use the syringe, stop air, and put it in the anterior chamber. And you wait around 1 minute, washing inside the anterior chamber, and you will see a fantastic result, stopping of the bleeding. And you will continue to make your surgery. This is one way. One way is to use plastic. Put the visco inside the chamber, waiting 1 minute, and after you wash the chamber, you will see a fantastic result. No bleeding, and you will be able to continue your surgery. What you have to understand is about those technique is put the liquid of a gas inside the anterior chamber, the pressure inside increase, and it would be impossible for the blood coming from a vein or an artery to inside the anterior chamber. It's essentially physics. The action is the high pressure, and the result is the stop. And we have to think about when you see the students when they are on stage, you can see an accident, bleeding inside the anterior chamber, and you can. That's why it's very important, very important to have to know, you have to do when this accident become. I want to thank Dr. Ivo and all of you for listening to my small speech, and thank you very much. God bless you.
Oh, thank you very much, Terry. It's an honor to have you. We want to expand this community to have colleagues from all over the world to understand your experience. And I think in a very short comment, you are giving us tips for something that is very unusual but could be very dangerous. So thank you very much. And then again, we are just about to finish. I just want to thank all the panel. I think today was a great day. I think we're learning a lot. I think we saw those numbers. Those numbers are something to be aware of. There is a lot of colleagues out there with the dream to become a cataract surgeon, and they see almost no path or no ways to do it. I think that's changing because of not only technology, but a good methodology. The methodology we call the wormhole. Let's try to use technology and a good methodology, understand how adults learn, and we can learn faster. But learn cataract surgery is not only about knowing, the technique. It's about Well, we love the online mentorship. I think we said the word mentorship so many times. I think Ladger did an amazing quote about not everybody, has the luck to have a mentor. I think with this portal and this community, we want to give everybody a mentor. We have simulation. Borja told us everything he's doing. Everybody talked about not only virtual simulation but artificialized simulation. Then there is something very important, and we think there is a new learning curve, but then you need a couple of cases with human beings. That's going to be, we can transfer you knowledge, but then you will need supervision for the first 10 to 20 cases. And there is also options about that. But always think about what comes next, because then you need the operating room, you need a team behind you to help you do cataract surgery with Phaco. And we think the best thing we can offer you is a community for always help you, other colleagues giving you advices for cases and for everything. So we believe in this new learning curve in which the patient comes after you have a lot of knowledge. Okay, I think this is very important. I think this is one of the main conclusions of the day is try to learn everything now you can with technology and a methodology, so that when you start with the patient, you have a lot of knowledge and experience. This is how we deconstruct surgery.
Phaco
We love,
emulsification.
sorry about the volume, we love to take the patient outside the equation, to deconstruct surgery, to have a new perspective of surgery, and remember the three pillars from Phaco mentors, right? The psychomotor skills, what's in your hands, the decision making in your head, and also the mindset skills during surgery. As Borja said it, we believe in simulation. Simulation is not only for psychomotor skills, but also to have repeatability in simulation. Remember, guys, almost all of you said that there is no chance to do complications or hard cases. Well, in simulation and artificialized, you can do that. There is also something about learning in groups. We did this just before COVID with the amazing Luis Escaf in Barranquilla, Colombia. So we had 30 surgeons from all over Latin America learning together with 6 stations, with artificial eyes, with the real machines you're going to use. So we are all about learning together in something called the constructivism theory, and we believe that we're going to have surgical ecosystems in the future looking like this: learning with colleagues, learning with mentors all together. As we said before, simulation has been proved. You can see there a 38% of reduction of posterior capsular breaks in this amazing paper from Dr. John Ferris. And this is important. This is not only good for you, but for patients and even for the healthcare system. As I said before, different places, different solutions. There is a new way of doing things, and prepare yourselves for what comes next, right? Try to have a mentor to pick very, very good those next patients. Which kind of cataracts are you going to do? This is again, the program, just very quick. You can take a picture from the QR and follow some information, and we will be in touch with you. Um, this is it for today, and I will love as the costume of Ophthalmology University. I will love a quick comment to end from all the panelists. So Ladger, you can start.
That was a great session. I think it's very important for everybody, for every young colleague who wants to join our fantastic world. And let's just work all together that we can realize it.
Thank you very much. Luz Marina.
Well, thank you. It was amazing to hear everything. And just maybe to add something up that I think it's going to be very useful is that all our trainees, they have and they keep bitácora, we call it in Spanish. It could be like a portfolio, like a logging. So not just recording the surgeries, just writing down the parameters. For instance, we have a big page in Excel. I could share it with you if you want, where we have the timing, the liquids, the fluids, the parameters, the CDE they used, because you have to grow with yourself. You have to compare with yourself when you're growing up. Well, and always, because you cannot compare with other trainees. We have different skills, we come with different backgrounds. So the way that they can see for themselves and see how their learning curve is increasing, they can, with that graph, they present it also with, they present the graphs based upon the Excel sheet and with the parameters and all those things that are going to be useful because they can record their own things, not just recording the surgery, recording their loggings. Thank you.
Thank you very much. Anya?
Well, I'd like to say to myself and to my co-panelists, to everyone, ask questions. Nobody knows it all. Ask questions. If you find yourself in a tight corner, ask someone. I still have, since I met Ivo online, we've been chatting, we've been calling each other, ask questions. And I've learned a lot from him from a distance. My trainees, I keep in touch with them. I share my challenges with them. Nobody has all the skills. Nobody knows it all. So when we ask questions, we get better. I am proud meeting Boha, and what he said is stuck in my head. It's not in speed, it's in quality. Thanks, everybody.
Thank you very much. Thank you very much, Anya. Vito, a couple of words.
Thank you very much, Ivo. Thank you very much to everyone. It was very, very interesting. All the videos, all the slides, very, very interesting. So I think you're right. Mentor is the key part, and have access to these new facilities also very good way to start. Thanks again.
Thank you. Thank you for your time. It was a pleasure to have you. Thierry. Thierry?
It's me?
Yeah.
This is not good.
Just some
You hear me?
last words. Last words for the entire.
You hear me?
Yes.
I want to thank everybody very much. And
yeah,
sorry,
the connection is not very good. Sorry.
very, very amazing. And
Borja, just few words. Last few words.
When you make surgery, be sure that one day you will face competition, and you will remember what mentor taught to you. And I think that is very important to have a mind. Very, very important. Thank you. Thank you very much.
Thank you, Jerry. Thank you, Jerry, for being here with us. Borja?
Yes, thank you again, Ivo, for the kind invitation, and thank all the fellow speakers. I'm going to give a last thought to us as community. I think we should switch the paradigm of teaching and learning surgery and stop thinking about the ways of teaching as they were in the last century and start thinking about the future ways of teaching and learning. We have a lot of tools that we didn't have in the 20th century that we should definitely take advantage of. Then the next generations are going to be very lucky if we put a lot of thought and a lot of love into this.
Thank you very much, Borja. I agree 100%. Francesco?
So thank you very much, Ivo, for this opportunity, and to all the panelists. The last tips that I will say, don't think that if you had no complication after 100 or 200 cases, you are a good surgeon. I always think this year I'm a better surgeon than last year. So is completely is always a process. Okay, we can always learn from ourselves, we can always learn from others. So every year I say, I mean, I'm amazed about this thing. Last year I thought that I was a good surgeon, but this year I'm definitely better than last year. So keep learning. Okay, thank you.
No, thank you for the time. It was a pleasure to have you here with us. People are very, very happy. Amazing comments. So let's hope to keep doing activities like this, right? I'm gonna keep pushing and invite you guys for many, many activities. So see you guys soon, okay?
See you. Bye.
Bye.
Thanks.
Bye bye. Take
Bye-bye.
care.
Thank you. Bye.
Bye bye.
Thank you.
Bye.